क्या हाल है रजीव द ग्रेट?
आकांक्षा,
यस सर।
अल्ताफ सर से बात नहीं हुआ क्या अभी?
अभी हुई सर।
He is there.
सर ही इज हियर सर। सर वी आर लाइव नाउ सर।
क्या हाल है रजीव द ग्रेट?
Fine, sir. आप बताइए
Good
सर, आप कैसे
evening,
हैं?
Dr. Jayant. I'm here only.
Yeah, Altaf sir, long
How are
time.
you? Yeah. How are you?
Missing you so much.
Yeah. Of course. Actually, I remain very busy with the hospital. Actually, having the government job plus PP, Dr. Vikas knows.
We
So
are
it's
missing
quite
your hospitality also.
Yeah.
Hospitality.
Of course. It's quite hectic, actually.
I know that.
Yeah.
Sir, we can start now.
So you give the introduction of the moderators and the speakers, and then the first.
Yes sir, we can start sir.
Yeah, you start that introduction.
Okay sir.
The theme of the webinar.
Yes sir.
The moderators and the speakers.
Yes sir. So good evening everybody. Welcome to the academic sessions conducted by ASAMI India. We're starting with the North Zone webinar today, the theme-based webinar of deformity and non-unions as a concept for tonight's lectures and case presentations. Joining us are our president and also the moderators, respected Altaf Kawoosa sir from Jammu Kashmir, and Mangal sir will be joining us soon. I'd like to welcome Suresh Bhola sir and Vikas Gupta sir from the North Zone, and our esteemed panelists of case presenters. So without further ado, I would request Vikas sir to kindly start his keynote talk. Thank you.
Can you see?
Yes, sir, visible.
Let me actually. Sorry, actually it's going. Visible now?
Yes, sir, visible.
Okay. So good evening, friends. At the outset, I would like to thank ASAMI India for inviting me to speak on any relevant topic. So I will not be speaking on non-unions and deformity. There are a number of esteemed speakers, but I'll be sharing with you that we do not get a situation like this. A patient with a non-union above and not following the principles of distraction osteogenesis had a non-union below. So let's understand some of the principles of distraction osteogenesis given by this genius, Elizarov himself. So what is distraction osteogenesis? A mechanical induction of new bone between two viable bone surfaces that are gradually pulled apart in a stable mechanical environment. So remember these two words, controlled distraction, the stable mechanical environment, to get a good regenerate like this. In fact, a bone formation can occur parallel to any direction of distraction. Could be horizontal, could be vertical. So what I have coined this, that it's an in vivo bone tissue engineering, a physics term, an engineering term, that any bone can be stimulated to produce new osseous tissue, irrespective of the type of fixator. It could be a monolateral, it could be circular, or it could be an intermedullary nail, provided one follows the biology and the biomechanical principles, which I'm going to discuss now. So those who are interested in history can remember the first documented lengthening was given by Alessandro Cordivilla, an Italian surgeon, published in American Journal of Orthopedic Surgery in 1905, by doing open osteotomy and calcaneum traction. Then there were a number of surgeons who used different kind of apparatus. However, Wagner in North American and Di Bastiano during 70s became highly popular because of their orthofix, but none of them followed the principles of distraction osteogenesis. So it was the Elizarov who gave the principle of tension stress using primitive devices such as bicycle spokes and the bicycle ring, and gave this principle of tension stress and coined that distraction of bone end creates an environment of stress and strain, which leads to formation of regenerate directly by intramembranous ossification. bypassing the cartilaginous phase. And he did experiments on canine tibia, which corresponds more to the human bones. And these experiments were later reproduced by James Ranson from Arkansas because of the original literature was in Russian language. So he outlined the factors for the successful regenerate formation, which I'll discuss one by one, beginning with importance of stable fixation. So based on the experiments, the Elizero, he first did an experiment where assembly was grossly unstable. Either could be a single ring, inadequate thickness of the wires, or wires were not properly tensioned or not properly placed. So let's see what happens when there's a gross instability. So there could be two divergent outcomes. Either the assembly is too loose to distract, which can result in premature consolidation. Okay? Or most likely, the macro motion induced by instability can lead to fibrous non-union if there's a gross instability, or could be a relative instability. It could lead to cartilaginous non-union because of the disruption of the osteogenic bridge. Now, any assembly which has a stable fixation, like double ring block, following the biomechanical principles, proper crossing angle, properly inserted and tensioned wires with stable bone interface, will result in high level of osteogenic activity with direct intramembranous ossification. So what we conclude from this, that any frame which you use for lengthening, use for deformity correction, should be as stable as possible, and this stability should be maintained throughout the treatment period. Now come to the next point, appropriate osteotomy, which is the cornerstone of any any Elizero application. Again, they did 3 types of osteotomy in a 4-ring stable frame. Other parameters were kept constant. An open osteotomy, which the Bastiani group were doing with a large incision transecting the periosteum, cortex, and endosteum, like a traumatic osteotomy. And what we commonly do, percutaneous 2/3 osteotomy with a small incision with a medial and lateral cut, and the posterior cortex is cut through the rotational osteochalasis, versus the closed osteochalasis, which actually you all of must have seen this picture, which actually Elizero did himself with almost like a minimal damage to the nutrient artery itself. This picture with dye shows that nutrient artery is still intact, which is now, it is impossible to reproduce. So what they observed, an open osteotomy, which leads to complete transaction of the osteogenic elements, including marrow, leads to delayed appearance of the regenerate, as well as delayed appearance of the consolidation. Although osseous tissue is formed, but it is delayed. So what you see on day 7 with 2/3 osteotomy, you see with day 14 with open osteotomy. So when you have the consolidation at day 77 with 2/3 osteotomy, it is day 109 with open osteotomy. So you have to delay even the latency if you're doing the open osteotomy. With closed osteochalasis, which is difficult to perform, it can lead to robust bone, in fact, premature consolidation. So what we normally do and advocate is percutaneous subperiosteal 2/3 osteotomy, which is also known as low energy osteotomy, with maximal periosteal and endosteal sparing and completed with rotational osteochalasis. However, having said this, some of the authors have outlined the importance of endosteum for regenerate formation, and they have specifically said that periosteum is more important than endosteum. Hence, a gigliosa osteotomy, which was popularized by Dror Pele, and you can see the technique in this article, although it was given by an Afghan surgeon, Abdul Petkes, also results in a satisfactory regenerate, which is one of my favorite, because you have the clean cut and you need not disassemble the apparatus. Although there's a transaction of the endosteum, but periosteum is spared, and there's a recanalization of the medullary vessels during the latency period. So what we conclude from that, whatever technique you may be following, but make sure it remains atraumatic as far as possible with maximal preservation of osteogenic elements. Now coming to the properly timed latency interval. So what is latency? My younger friends may not be knowing. It is a delay before you start distracting. And normal latency is 7 days. But why 7 days? So because of the recanalization of the medullary vessel, which I have just told you. And it has been seen in clinical experiments that a delay before distraction, a latency of 7 days, results in a good regenerate. However, a latency period varies. It can be individualized. It could be shorter latency, less than 7 days in a younger child. A classical metaphyseal osteotomy, which has a greater blood flow, inherent stability, and large surface area. And latency may be prolonged. Also, if it's an open osteotomy, I've just told you, which can lead to even periosteal damage, or a diphyseal osteotomy, so you can individualize the latency. Now, what is rate and rhythm? These terms. So rate is a millimeter per day at which you distract the bone surfaces. And rhythm is number of distractions per day in equally divided increments that total the rate. Now let us see the importance of rate. So different rates of distraction were tested in canine bone. So excessive rate, when they found excessive rate of more than 2 millimeter per day, so to get the early regenerate and early bone formation, but actually it reversed. You have the poor regenerate formation leading to non-union and pain. And probably this was the reason the earlier surgeons failed, like the Wagner or Di Bastiani. They were doing the traumatic osteotomy and used to distract at one go. So because the bone formation also occurs at the cellular level. So you cannot procure it in mitochondria with a large excessive rate. It's a rate limiting factor. Whereas slow rate of distraction can lead to premature bony consolidation of the regenerate. So what we conclude that a good regenerate forms with a 1 millimeter per day in most of the cases, because this is also the normal rate of biological growth. Our hairs, our nervous tissue also grows at this rate. But remember, friends, the rate of distraction is also varied like rhythm, and it is based on the central radiolucent area, which is known as fibrous interzone. I'll come to that. What is fibrous interzone? Now, again, is there importance of rhythm? Why not we do once a day distraction? Why we subject the patient to do 4 times a day or 3 times a day? It's so disturbing, so annoying. So again, experiments showed that once a day distraction or sporadic rhythm in fact inhibited bone formation. The Elizero himself conceived an apparatus, auto distractor, for continuous distraction to simulate the biological clock, 1 every minute, so that we have 1,440 distractions per day. But what actually resulted? It resulted in premature consolidation with excessive bone formation. So now we commonly practice a distraction of 4 times a day, which results in minimal pain and good bone formation. So let's always follow the dictum given by Elizero himself. Now, functional use of limb. Is it important? Let's see this actually video itself. So this is the original video where Elizero actually called his patient on the second day and asked him to walk on the frame. So this is very important, weight bearing and motion. It gives a cyclic compression to the regenerate. It helps in early maturation of the regenerate. So make sure that your patients, the frame is stable enough, the frame is pain-free, so that patients are able to walk the very next day. Now, is there a role of other metabolic disorders or conditions on the regenerate formation? So clinical studies as well as animal studies have shown that conditions like diabetes, bone mineral disorders like rickets, osteomalacia, or syndromes like intestinal malabsorption have a negative effect on the newborn formation. In fact, drugs such as corticosteroids, anticoagulants, or substance abuse like chronic alcoholism and smoking also influence bone healing and results in poor regenerate. However, short course of antibiotics and the NSAID, except indomethacin, have a very little effect on bone healing. So once we are through this, let us see what histological events occur during distraction, which are modified by this various factors. So this is schematic diagram which shows that during the distraction phase, you have this bone junction interface, and the bone is formed in the form of microcolumns, which is known as primary mineralization front, along with vascular sinusoids. And this fibrous interzone remains avascular unmineralized like a growth plate in a child. So let's see what happens. The latency phase during the first 7 days is similar to the fracture stage of fracture healing. The gap is filled by hematoma and inflammatory cells, and as you start distracting the mesenchymal cells, they organize a bridge of collagen and vascular sinusoids, which is known as fibrovascular bridge. And this bridge gets broken if the frame is unstable. So during the first week of distraction, this day 7, basically day 14, the fibrovascular bridge, which is now around 6 to 7 millimeters, is relatively avascular, unmineralized, and is known as fibrous interzone, the term which I have been using frequently, like a growth plate of a distraction osteogenesis. As the distraction proceeds from day 14 to 21, the periphery of the host bone surface is invaded by vascular channels, and invasion of fibrous interzone is by vascular channels. As a result, the mesenchymal cells turn into osteoblast. Osteoblast lay down the osteroid, which gradually mineralizes into microcolumns, which is known as primary mineralization front. And you might start seeing new bone approximately 3 weeks after the surgery at the either end of the corticotomy, either end of the host bone surface, if you have a good quality X-ray. And that is the reason you want to have a stable frame. An unstable frame can induce macro motion, which can disrupt these microcolumns. So at the day 30, that is the day 21, at the end of second week of distraction, these bone spicules, which is known as primary mineralization front, extend from each corticotomy surface towards the central fibrointerzone, and they resemble what is known as stalactites and stalagmites. I hope those who have been to caves like Ajanta Ellora can remember this picture. In fact, stalactites, they grow from up and stalagmites grow from below, similar to what you see in this picture. So this is a very characteristic picture, which is known as zonal progression. And this central radiolucent zone of fibrous interzone and peripherally mineralized zone of primary mineralization front, this is known as zonal progression. And this is a guide to the rate of distraction. How? If this fibrous interzone has a thickness more than 1/2 of the gap or more than 8 millimeter, it shows that rate of distraction is too fast. You need to slow down, or you may need to even stop. But if fibrous interzone is barely perceptible, less than 2 millimeter, there are chances that it may lead to premature consolidation. And rate of distraction is too slow, you might have to increase the rate of distraction. So length of the regenerate is gained by increasing the length of the bone columns, which you can see in the blue color. At the end of distraction, during the consolidation phase, the fibrous interzone is ossified with bridging of the microcolumns and the vascular channels. However, the new bone produced is not as stiff as the original bone, and it gradually, with time, even months or years, remodeling occurs to the lamellar bone with Haversian system. But remember that new bone is ultimately similar to the original bone, both histologically and biochemically. So just to finish, I'll share 2 examples. It has number of clinical applications, both innumerable applications. The principle applies to everything: limb lengthening, deformity correction, non-unions, and bone transport. Let's say this 22-year-old girl had a failed plating somewhere else, presented with pain, swelling, shortening, non-union. So following these principles of distraction osteogenesis, she underwent the bone transport, the resection of the after debriding the bone ends. And that's after 1 year follow-up. She had a good function and complete union. Another boy, he had a multiple surgery in the past. He presented to us in a very anxious, depressed state with non-union, shortening, and you can see there's extensive scarring. He had previous surgery, like someone had applied the fixator like this. I don't know how, but the way it has been applied. And finally, the surgeon also thought of applying this Ilizero when he had a picture like this following debridement, but it also failed. Presented to us now with this docking site non-union osteoporosis. So we had a 4-ring frame, and this child was allowed weight bearing during the distraction, and ultimately he had a good union with good function. So to conclude, the distraction osteogenesis is a powerful tool. It's a biological law, like a law of gravity, a law of tension stress, which helps to regenerate bone as well as soft tissues by the process of neohistogenesis. And it has countless clinical application. And in fact, this principle has saved many patients from going into amputations. And we have saved many limbs and made the patients up and about. So thank you very much. And I'll stop share now.
Thank you, Vikas.
Thank you, sir.
So any questions, you can put it on the chat and Vikas will reply on the chat, or others can reply on the chat. We'll go to the next talk. Suresh, right?
Yes, sir.
ऊपर प्ले का बटन है. Right. और right को. Just play the play button on the right side. Yeah. You were there. Almost there. उसकी जरूरत नहीं है. Play button दबाओ. हाँ. Yeah. We can't hear you.
Sir, you can start.
Am I audible, sir?
Yeah, we are audible, sir.
Respected masters of the Elizro, my dear friend, my simple and humble presentation is about a 44-year male who is walking like this and is a poliotic patient. And there is no loading of the right lower limb, and he is a chronic smoker. He takes alcohol frequently, except Tuesdays and Thursdays, and out of business since last 5 years. And these are the X-rays. There's non-union in malposition. And my dear friends, five years back also he came to me, and these were the X-rays. Somehow he got operated and lengthening of the leg was done. And with this, earlier he was loading, now he's not loading at all. And there is non-union. There is non-union of the tibia because he underwent lengthening of the tibia for his treatment. We can do plating, nailing, or electrofixation with or without bone grafting, so that this bone should unite, the tibia should unite. And even if this tibia unites, let us preview what will happen. Will he be able to walk? I think he will not be able to walk even if this tibia unites, because there are other deformities. And due to those deformities, even union will be hampered. He's not loading the lower limb. If functionally loading lower limb has better chances of union rather than non-functional hanging lower limb. And there are different strategies for the union from non-union and making the limb functional loading while walking. The treatment is divided into two parts. First, we should concentrate on union of the leg. In the first stage, the main aim should be management of the union. And in the second phase, after 6 months, we can think of limb which is functionally loading. And why not combine both the things in one go? Convert the non-union into union and make it functionally loaded limb by adding a supracondylar extension osteotomy. Making the limb functionally loaded by supracondylar extension osteotomy will make the union faster. Both the parts, they are complementary to each other. With these thoughts, prior to intervention, we did frontal plane full length CT scans to find out what are the AP parameters, what are the sagittal plane parameters, how much is non-union contributing to the deformity, and how much is knee contributing to it. The muscle charting was done. The femoral frame was prepared and it was documented. Similarly, tibial frames with whatsoever angulation is to be corrected, they were made and it was documented. Then the things, they were simpler. In the same sitting, we did supracondylar extension osteotomy and made multiple osteotomy at the level of the non-union of the tibia. And these are the results. Full length X-rays, they were done time and again, so that we can have a limb which is functional. Minute changes, they were done with the help of hexapod, so that we align the limb in best way. And these are the results. As Dr. Vikas Gupta has rightly said, the loading of the limb will lead on to more chances of union, more chances of function, and we can titrate these things. You can see the amount of new bone formation at the end, at the site of the non-union, as well as the supracondylar osteotomy that is also uniting. The carry-home message with this is, if the non-union was operated without alignment of the limb, the chances of union would have been less. And even if it would have united the tibia, it would have been a useless limb because he was not using it. And again, after 6 months, we have again to attack that part, because the patient with union only, without an alignment, will not be able to walk. And making the limb functional by supracondylar osteotomy not only makes the non-union unite, but also changes the life of the patient and his family. Dear friends, as Dr. Mangal Parihar sir said in a conference in Indore, that lengthening in the politic should not be taken lightly. This is the end result of a lengthening which was done in the tibia in a politic. It is a serious matter. And another carry-home message is, if main issue is being treated, like in this case, the non-union of the tibia, you can suggest another procedure if you think that can change the overall outcome of the results in a better way. And with this, thank you very much, everybody, for giving me an opportunity to share this case with you. Thank you very much. That's all.
So, Suresh, how do you decide how much extension to give?
That was in the sagittal plane, we took the X-rays.
Yeah, and then?
Then
No, extension you have done at the supracondylar, no?
Yeah, exactly. But some amount of extension was also achieved at the non-union site, sir.
Correct. So, but how much have you given in this case?
So that there is locking of the knee. It is the titration in the function. The patient keeps on walking till he says, yes, now it's okay.
Correct. So it's not the numbers as much as
it's almost the number,
titration.
and later on it is the titration. functional titration, sir.
Sorry, just repeat.
Initially, we say 17 degree of flexion is there. Should I show that CT scan if you want?
No, okay. Just you can.
We just say 17 degrees there.
Okay.
Make him walk. If he's still unstable, we do more. And if it's too much in the hyperextension, we reverse it. So daily 1 degree, half degree, we titrate it till we get a position in which it is neutralized.
So in your experience, how accurate is the number that you get? Meaning when you titrate, how many degrees normally you have found that, okay, I have to go maybe 2 degrees more than what I planned or 5 degrees more than what I planned?
It is never the complete whatsoever I have done in the operation theater. It is almost near that. But ultimately, just like Taraju, that central point has to come. You have to decrease or increase the weight of something which is being put into so that the central, that thing.
Dr. Bhola.
Like this.
Altaf, yes.
Hi, Altaf.
Hi, sir.
Hello,
Dr. Bhola, actually, I understand that you would be basically thinking that the mechanical axis has to go in the front.
Exactly.
So that is the exact point which you can plan beforehand so that your recurvatum osteotomy works.
Exactly.
Yeah. So that is so naturally, unless you get that axis in front, it will not work. So it doesn't mean simply numbers. So the moment you are getting the axis before having hand to knee gait, the patient's axis is behind.
Exactly.
So the idea is that you get the axis in front and you are done. So yes, it's right that how much you need that you can titrate. But the basic idea is for the learners, for the beginners, they must understand that it is the axis which has to go into the front.
Right.
The weight bearing axis, mechanical axis goes in the front and the knee gets automatically locked.
Yes, sir.
No, that's exactly the question I asked, and he answered in terms of, now that you have to do 17 degrees of correction, but that 17 degrees may not be enough, and you have to keep, if you find that it's not locking at 17 degrees, then you have to keep
going on,
increasing it till the patient is able to lock.
Right, sir.
Great. Thank you.
Thank you very much, sir.
Thank you, Dr. Suresh. So we'll now go to the case presentation. Who's?
Sir, Tarandeep sir from Amritsar.
Yes, Taran. Tarandeep can start.
Hello.
Yes, sir. You're visible and audible.
So I am presenting case of aseptic non-union. My case is 23-year-old male who had a history of roadside accident. He had fractured both one forearm, compound in nature, grade 3B type. Initially managed with a debridement, bone resection, cross-leg flap, and external fixator. Now he came 3 months after the injury to me for the further management. At present, he has shortening with bone loss, stiff knee, unable to dorsiflex ankle. Passively dorsiflexion is possible little bit, that might be at the fracture site, with no neurological deficit except over the cross-leg flap. There is no discharging sinus and the blood parameters are nearly normal. These are the pre-op x-rays of the patient, and with these are the clinical pictures. Cross-leg flap and with the split skin grafting, it is done on the especially on the lateral and medial sides. What I did was, because there is no sinus, I put simply Elezero. With the manipulation of the knee and ankle, I did corticotomy at the proximal third region. And these are the x-rays of the 10 days distraction. I distracted at the rate of 1 mm per day, as already explained by Dr. Vikas. These are the x-rays at 1.5 months of the distraction. everything is going fine. And ultimately, when the distraction continued, there is an invagination of the skin occurs at the distal non-union site. Along with, I noted that there is external rotation deformity. That is, the foot is lying in little bit of external rotation. And this is a picture showing the invagination of skin. That is a split, that is a cross-leg flap that is going in between the fracture fragments. At the time of docking, that flap has been cut and the non-union site is docked, sutures applied, and along with that, at that time, I have corrected the rotation that can easily judged from the picture. On the right side, foot is on the external rotation side, and I have aligned it on the left-hand side. That can be also seen with the help of centering bolts that are on right side, that they are in a straight line, whereas in the left side, the proximal two are in line, and right side, I have done the internal rotation. Ultimately, that docking site healed well without any major complication, and distraction continued after the docking. This is a final X-rays of the patient when I fully corrected that, fully lengthened that limb along with the limb length equalization. And this docking site is showing fracture site healing. Non-union site is also showing the signs of healing. And total length of 21 centimeters is attained by the distraction of this frame. So these are the X-rays after the fixator removal. And these are the clinical pictures of the patient showing function. So there is a little bit of mishappening that I am adding my experience, both prospective as well as retrospective analysis of my own to this case in the form of clinical as well as radiological learning curve. So first I will explain my clinical learning curve. I already explained about the rotation of the patient I have corrected that I did miss in earlier my fixation. This is the beauty of the Elizarov fixator. Had I put LRF in this case, it will be a big mesh for me to correct that rotation. I have to reapply that fixator. So this is the Elizarov who gives me chance to correct that rotation. Another clinical aspect is the impingement of the skin. I have seen the X-rays while sitting in the room. I have not seen the patient for last 2 to 3 months. Then I realized that there is loss of edema. You can easily see from this picture, almost the girth of the calf is equal to the thigh size. There is a lot of impingement which cause sores and ultimately wound over there. So I then apply judicially about the treatment to this swelling in the form of limb elevation, exercise, compression bandage, and then I got the correction there. So coming to the radiological aspect of my learning curve in this case, this is the preoperative X-ray of this patient knee joint. This is the X-rays in the distraction period in the 10 days and the 1.5 months. And this is the postoperative X-ray. In these X-rays, I noted that in retrospective my analysis that I didn't get it earlier, that my fibula is shifting down. So when I am distracting, I am seeing that region rate is very good. But at that time, I didn't realize that my fibula is shifting down. There is a tibiofibular dislocation and my fibula is migrating distally. So I'm lucky enough that I don't get CPN palsy in this case. So I want to highlight this point to the learners and to the so that it won't happen in the future. And why it has happened? Because my fixation to the fibular head is very less. As I noted that there is a dent and little bit of the bone stock is there when I am fixing that proximal tibiofibular wire with the proximal tibiofibular wire. Why it be with the distraction that part has broken down and it has shows dent there. So if it has happened nowadays, I will fix it with the orthodes, the proximal joint, or my wire should be in the center of the fibular head. So another learning curve, radiologically, these are the X-rays after 13 years of my fixator removal. So it is showing now the ankle osteoarthritis in this case. So I want to ask seniors and various panelists that why it has happened. It is a matter of debate for me. It's a good learning point for the others and me and others. So this is the working video of the patient. And with this, I end with the take-home message that Elizarov is a versatile fixator with a three-dimensional stability. It can correct deformities in any plane. Up to any extent, bone can be lengthened. Almost always the rate limiting factor is the soft tissue. Though it has certain limitations that can cause complication, which can be prevented by proper monitoring. Clinical and radiological correlation is a must for the proper follow-up of the patient. It has long learning curve. Prospective and retrospective analysis is must for getting the knowledge to decrease the complication rate in the future. Thank you so much, sir.
Good. So that last line is also said as the more you know, the more you realize how little you know. And I think that is most important. Doing a self audit whenever you have your cases, you should look at them, critically in terms of, did I got everything well? What was the only thing I think remaining in this guy was a little bit of a foot drop, which was not your fault. It was the fault of the original injury as well as the debridement. So one thing that could be done possibly to improve that is हाँ बोल ना हेलो हेलो सुनाई दे रहा है नहीं सुनाई दे रहा तेरा आवाज आ रहा है इधर
हाँ जी सर आ गया सर हाँ जी सर
so the one thing that could be offered to him to sort of slightly improve his gait further is some kind of a tendon transfer or a tenodesis to keep his foot up.
Okay,
otherwise
sir.
I think this is a classic example of an elixir of bone transport done well, which can take care of all kinds of severe trouble. One thing you didn't mention over here is your treatment time. How long was this fixator on?
Sir, I have calculated about a year and a half, sir.
Correct. So that is supposedly an objection to the elixir, but this kind of a severe problem, as long as the patient is ambulant, that 1.5 years is not, I would say it's not such a big deal. Any comments, suggestions, Altaf?
Yes, sir. Sir, I was saying, Dr. Taran was saying about why did he get that ankle osteoarthritis. So personally, I think that there is some kind of a procurvatum at the distal end of the tibia, and which usually tends because I think that you don't have a foot frame included in this, perhaps. So if you analyze, maybe there is basically little procurvatum and which is compensated by the dorsiflexion at the foot. That is why you have an anterior lipping of the talus and the distal tibia, which is letting it go towards the osteoarthritis. I think Dr. Mangal, you agree with that.
Sir, but the osteophytes is also seen at the posterior aspect of the ankle.
No, you look at if you can go back to the last X-ray. I can find because actually the anterior distal tibial angle is on the lesser side. It's not 90. So this is because like you audited, I have audited my also patients and I did get this thing.
Okay, sir.
So this is, if you see the overall mechanical axis, there is little procurvatum in the distal at the ankle. So that is why as a compensation, the foot will go into dorsiflexion and then this is rendering it towards an osteoarthritis. This one. Now look at the angle. If you maybe by calculation, you might find what tends to happen.
Yeah, but then on the other hand, usually whenever there is deformity in the plane of motion, you don't get osteoarthritis. For example, flexion deformity of the knee.
No, sir. If you see the compensation now, the foot, in order to that, since he has had foot drop also, like you pointed out, If a patient with a distal small procurvatum has to ambulate, he has to dorsiflex. So, because if you have some kind of a procurvatum as a compensation at the ankle, he will keep the foot in dorsiflexion. That is hitting,
Okay.
and this axis is hitting anteriorly.
Go to that last X-ray where you had a bigger view of that. You had
Yes,
a
look
this
at
one?
this now.
You had
Look at
one
this
more.
now. For example,
Yeah,
if you,
yeah.
Dr. Dharan, if you now look at this, the union side, though it's absolutely fine enough, but there might be some kind of recurvatum, and maybe you have some kind of FFD at the knee as well, which is throwing the sagittal balance towards procurvatum at both ends. And a resultant foot deformity as a compensation for dorsiflexion, it narrows down and leads to osteoarthritis.
Great. So that is one new thing to learn. Rajesh,
Perhaps I
Mr.
think you
Rohila?
agree.
Yes,
Yeah, go.
I can say one thing that I have seen the fusion of ankle joint in the long after 10 to 15 years the patient develop the even arthrodesis of ankle joint. He is lucky that the patient is having only some arthritis. I have seen fusion of ankle joint in many patients.
But that is usually because of a pre-existing ankle injury, I would say. It's
That
not.
may be the reason. That may be
Yeah.
the reason.
We don't know what injury has happened to the cartilage at the time of
Yes.
the original fracture, and then that can go on. That can go on to sort of heal by bone. I've also seen a few cases
Yes, sir.
of that.
Taran,
Yes, sir.
you can see that as Altaf was saying, when you draw the distal anatomical axis, distal end of the tibia,
Yes, sir.
and the line along the calcaneal diaphysis.
Yes, sir.
So in a neutral foot, the posterior angle should be 150 into 120.
Okay, sir.
So if it is less than that, that means here you can see it is 90 degrees.
Okay, sir.
That
Yes,
means
sir.
patient is having 30-degree equinus.
Okay, sir.
The
Yes, sir.
Sir, the anterior distal tibial angle, which should be round about 80 degree. Here it is more than 90 degree.
Sir.
Once this happens,
Yeah.
this overall later on, initially there will not be any osteoarthritis, but really with the passage of time, this will lead on to our osteoarthritic changes due to the compensation which later on osteoarthritis developed. Once the plateau is reversed, distal tibial sagittal plane plateau is reversed. Instead of 80 degree, it might be 95 or 100 something. Because if we make a line from the posterior and anterior, it is reversed and slightly
Yeah,
more than 90.
that is what I am asking Dr. Altaf, that my fixation is on the opposite side. It should hit anteriorly, but I got the osteophytes posteriorly.
It is not the only
No, it's not on.
osteoarthritis.
Right. So I think, but the LDK, as everyone has
Give me
pointed
a
out.
moment. Sir, give me a moment. Dr. Taran, what do you say that you should have had osteophyte posterior? You mean that?
Yeah.
No, this is what I'm telling you. If you go to the mechanics of the ankle, for example, if you have ankle valgus you have valgus at the ankle. What is the foot compensation? Foot compensation will happen at the subtalar joint. It will go
Yes, sir.
towards varus. Now
Yes, sir.
you have a distal tibial procurvatum. Where will the compensation come from? The foot has to be grounded. Foot has to be platigrade. It is
Yes,
the
sir.
talus which will intend to hit it anteriorly. That's why you'll get an osteophyte anteriorly. You won't get it posteriorly. Got my point?
Sir, that is the reason I got the posterior osteophytes in this X-ray. Anterior
That
part
might
is
be,
okay.
that might no. Why it's not okay. You see the lipping on the anterior side. The talus anterior side is tending to flatten out. It is trying to match this tip of the procurvatum tip of the distal tibia.
Okay.
The anterior part of the talus is flattening.
Okay, sir.
You can appreciate that. And
Yeah, but the
and as a secondary change,
point is that you have to aim for it to be normal. If you have it abnormal, then
Yes,
it will
sir.
create trouble.
This way.
But
Right?
yeah, Dr. Tarandeep, you have managed this case very well. These are minor points. You see, you have done 21 centimeter lengthening and achieved union. So
Yes,
this is
sir.
very well managed
It
case.
is applaudable.
Ah.
Thank you,
Absolutely,
sir.
Dr. Rajesh. This is just because
Let's go to the next case.
this is just because Taran wanted to audit it. That's why we are looking at the intricacies. Otherwise, there is no second thought about the wonderfulness of this case. Absolutely not.
Nice.
Thank you,
Currently,
sir.
what
Thank you.
Altaf says, if you have put a foot frame, probably this could be prevented.
Yeah.
Oh, okay, sir.
Tarandeep, you can stop sharing. Next person, please.
Thank you, sir.
The next person is Vikram, sir, from New Delhi.
Good evening, everyone. Now I'll be presenting a case of a stiff non-union with deformity of the proximal tibia. So what are the causes of non-union? One is the biology that, during the fracture, how much vascular loss has happened and how much vascular damage has happened to the bone. And the other is fixation, whether we have achieved adequate stability and how is the alignment. So reason for non-union with a malalignment is pretty self-explanatory. Now coming to my case, the case is of a 52-year-old female. She suffered from a road traffic accident 9 months back, and she came with a proximal tibia fracture, which was plated there only. When she came to me, she was non-ambulatory. She had a foot drop. She had a varus deformity with an FFD, and the distal locking screw points, they were infected because there was a discharging sinus present. This was the index surgery. There we can see, this is before she started weight bearing. Here we see that the joint has not been the joint has sort of broadened. The proximal tibia has broadened, and the locking plate which has been applied, the screws have not been locked properly. And this is when the weight bearing was not happening. And this is as soon as the patient started bearing weight. Now, this is what the body tries to do. If it tries to stabilize, that is, I think the body's priority is that it tries to stabilize itself, and in that process probably it has gotten more malaligned because the fixation is inadequate. There is no medial buttressing, hence the varus deformity has occurred. So this is when the patient presented to me 9 months post surgery, post the index surgery. And what were the issues which I identified was that the union was doubtful because as soon as I made the patient stand, it was very painful. So it was either due to the varus deformity or the non-union or maybe the fibrous union, which I sort of thought about it. Then the malalignment, the joint subluxation. Probably it was not more of subluxation. It was more of the proximal tibia opening up, becoming broadened. Then in this X-ray, we can also see that probably there was one implant, one screw which was in the intra-articular region also present. Then the infection and the foot drop. Now, intra-op, these two images which I have kept is specific because after I removed the plate and the screws, I intentionally kept this one screw because I thought this was holding that fracture pretty well. So I thought if I opened this, then this would probably lead to further broadening, especially because when I inserted my osteotome there, this is without me, hammering the osteotome. It was going through easily. So then this gave me an idea that, if there were two options in front of me. One, I could remove this screw and then probably, try to open the old fracture line, which was probably fibrotic, or the other, what I did. So I decided to go for a simple HTO. I tried to, keep the lateral hinge intact, and but probably it broke only. And it was too the old fracture lines were too sort of confusing. So I was not very clear whether I've opened opened the lateral hinge or not. Then I put in 3 wires in the proximal ring, 2 olive wires, to get more compression. Tried to compress it and make the proximal tibia a little less broad, and an additional wire. Then, since the patient was not from Delhi, she wanted to go back home. So I did acute correction and then fixed it with two further rings, one the middle ring with a wire and 2 pins, and the distal ring with 2 pins, and then check the alignment with the help of uh, that cautery wire. And then so these are the steps which I did. Then the patient went back home after the dressing. Then she informed me that the distal screw side that had started pouring pus. So and proper antibiotic after culture sensitivity was started for her, and she was advised to wait for the infection to settle down before weight bearing started. Weight bearing could be started. The other reason why I did not want to do weight bearing initially was that I was not very confident of my fixation in the proximal part, because though 3 wires are enough, but the bone in which those 3 wires were, that was sort of questionable in my mind. So so I wanted to protect it for probably a month or so before I would start weight bearing. So the infection sort of gave me an excuse, and I did the same. So after 2 months, I got this X-ray, and in that I saw that the bone was not coming at all, in fact. So then I gave her PTH injection for a month, and I started her on weight bearing, because there were these 2 factors which were in my mind, which were stopping the bone from formation. The next month X-rays sort of relieved me, because the bone started to come. The lateral hinge was looked to be united, and the healing was progressing medially. And this is after 4 months of fixator application. The patient was not willing to come to Delhi, so there was a local orthopedic surgeon who helped me, and with his help, I performed the patient performed the fixator stress test with me on the video call, and then we managed to remove the fixator after 4 months. And then the patient was sort of lost to follow up. Then she came back a few months back with this X-ray. Now the patient is walking pain-free, and she's able to do everything. The knee movement is around 100 degrees. But there is a healed sinus scar present at the level of distal screw side on the lateral aspect. But overall, the patient is comfortable and walking well. But there is obviously the component of a foot drop which is still there. So the alignment got corrected. The union was achieved. Probably the alignment was corrected, and the sort of stable fixation was given. Subluxation, because partially corrected, because basically we corrected the alignment again. Intra-articular implant, which was a problem, that was removed. Infection, so far it is settled, but by the looks on the X-ray, probably it may flare up once the immunity goes down. So I'm keeping my fingers crossed. Foot drop is persisting. I've advised her for either a foot drop splint or a tendon transfer surgery, but that the patient will decide and get back to me. So for managing a non-union with a malalignment, I think alignment and stable fixation is the key for union. No matter whatever your fixation element is, you can fix it with a Ilizarov, you can fix it with a plate, but the fixation element and the fixation principles never change. I think this can be kept as an extended indication for a high tibial osteotomy. Now, this is my first experience with a acute correction with an Ilizarov surgeon, with the Ilizarov fixator. Generally, with acute correction, we are doing plating. But in this case, because of the infection, I decided to go with the fixator itself. And obviously, if we respect the biology is going to respect us and give us union. So we have to take care. Thank you.
Vikram?
Yes, sir.
How will you lock the proximal, that is the proximal ring and second ring are now connected with the polyaxial hinges?
Yes, sir.
How do you lock that polyaxial hinges for making the patient to walk?
So because all the, since they are in different planes, so I felt that with this, it will not be a problem. That is why I allowed the patient to walk.
Polyaxial means it can move in any plane. So each
Yes,
hinge
but
allows it to move in any direction.
yes, sir.
That's what he's pointing out.
Yes, sir. But since there were 4 rods with polyaxial hinges, so I thought that this will sort of not, this will allow me to lock it.
So tomorrow what you have to do is take 4 rings, connect them with
Yes, sir.
4 straight rods.
Yes,
and
sir.
the same 2 rings, you connect them with polyaxial. Put your hand on upper ring and lower ring and move those rings side to side. They may not change much in terms of angulation.
Yes, sir.
But certainly they will change in terms of translation in some of the planes. Because you have to think, why did you not get healing in your osteotomy? One was you did an acute open wedge.
Yes, sir.
Which is not in normal bone. This is in damaged bone.
Yes, sir.
So that is one possible reason. Second possible reason is instability. That is also
Yes, sir. But
one of the reasons.
but eventually,
Can
probably it was more on good luck. But I think that initial few months, I only stopped the patient from bearing weight. So I think that may be one of the reasons that the bone it did not start to form bone. The other reason, what I was thinking, yes, sir.
Please go ahead. Please go ahead.
Yes, sir. And the other reason I was thinking that initial 1.5 months, the patient had a discharging sinus from the distal part. But I think that since till there is infection, the bone healing never really kicks off.
Dr. Vikram, my question, how did you do the osteotomy? You did it an acute osteotomy. What did you use for the osteotomy?
So just simple osteotome. I did not drill. I did not do anything. Just an osteotome.
Okay.
I just hammered it. The bone was actually quite soft, so I had no problems going through it.
Like what made you to do it as an acute correction? Would you kind of do it in a gradual manner so that you would allow the tissues to heal around, have some kind of an hematoma, have some kind of the raw material which would have built on to give you the bone? Like this is not the HTO in case of a native bone, where you would rely on the cancellous nature of the original bone. So the bone was defected already, it was infected as well as low in potential. So was there
Yes,
any specific way that you wanted to correct it acutely?
Sir, I wanted to basically my thought process was that since the patient was not willing to stay in Delhi, so for gradual correction, I like that the patient should be
It could have happened within a week, 10 days only, but then that perhaps would have given you a lot of respite, because ultimately we depend upon the raw materials that can be exploited. It is the basic new hematoma or new regenerate, something like that, which can be exploited to growing in new bone. Having this gap to begin with, then
Yes,
you
sir.
have to rely on the creeping substitution from the lateral end of the tibia. That is why
But sir,
perhaps, yes.
yes, sir. I agree. So that is why that was the reason why I got a little upset after the 2 months. But if we see this X-ray, sir, when I was doing the osteotomy and all, I saw that there is callus which is formed. So the bone was trying to heal, but probably it was not getting stable enough fixation for it to heal.
Vikram, have you done a
Not
fibula
only that, it
osteotomy?
was not a native bone.
Vikram,
Yes, sir.
have you done a fibula osteotomy?
No, sir.
Okay.
No, sir.
Do you think it is necessary there?
No, sir, because I thought the lateral, I did not open from the lateral side. So I
No, but
felt
here
the
there's a
lateral.
tibia fracture, fibula is already healed.
Yes, sir.
So that will
Fibula-
prevent your docking here. There's a gap here. Gap up that at the upper end.
Okay,
That your
sir.
compression, everything will not be happen properly because the fibula is already healed.
Yes, sir. Fibula is healed. Yes, sir.
Yeah.
But sir, the thing was that the lateral the lateral pillar, because the medial side has lost its height. The
I know.
lateral side,
When
the height.
you compress it, when the patient walks, the
Yes,
fibula
sir.
won't allow the medial side to go in contact.
But sir, that may happen but we wanted to maintain that height, na sir. If
Height
that
is not a
medial side
problem here, no, but
compresses,
it's a
then
non-union.
but sir, if the medial side compresses again, then again we will have a varus alignment. This is
You
more
won't
of a
have it.
corrective, not me, sir.
No, this will get correct. Now still there's a varus deformity. Once you do the fibular osteotomy, then you can correct everything. You are free to correct it.
In other words,
Okay.
Dr. Vasu is saying that, for example, had you intended the osteotomy in a typical HTO way, that would go
Yes, sir.
towards the fibula, and then you wouldn't need an osteotomy. Now that if you really have an osteotomy that is below and fibula is intact, it
Yes.
might not work.
Okay, sir.
Maybe those are the things. And to me, the
Yes.
biggest thing is that you created a big gap to begin with.
We'll go to the
Yes,
next
sir.
case. Okay, good case, Vikram.
Thank you, sir.
The next presenter, Rajiv, sir. So please unmute yourself.
Hello, am I audible?
Yes, sir. Please share your screen, sir.
Hello, good evening all. First of all, I would like to thank ASAMI for giving me this opportunity to present my case here. The talk of my today talk is infected gap non-union tibia. So this is a case of 30 years male who has undergone a road traffic accident and treated at the tertiary medical college. So the initial injury is open grade 3A tibia with 2 large puncture wounds, managed with a percutaneous plate as an external fixator, just to not to affect the knee range of motion. I think the primary surgeon has in mind. Simultaneously get infected, so they have make a incision, debrided the wound, and give the IV antibiotics. But the patient, because he is also having the head injury, went into ventilator. So regular orthopod become side by side. Regular dressings with the removal of bone pieces by the senior residents and residents take place. The wound had been grafted, but the patient is having continuous fever and the culture isolated pseudomonas and decline. So these were the post discharge X-rays. These X-rays showed a big gap non-union in the proximal tibia and the plate in situ. So this is how he presented to us. The patient is having a plate, the wound is grafted, the TLC and CRP, all the infected markers are high, and the patient is having, just a minute, and the patient is having stiff knee. So I removed the plate on OPD basis, get the X-rays done. The proximal tibia is also having all the diffuse osteoporosis, and the middle part of the tibia, the distal part, the distal segment, it is also getting osteomyelitic. So we have taken the patient for debridement, remove all the dead pieces and sequestrum, and put the cement spacer and close the wound. I've applied a 3-ring laser of construct in the tibia and taken, because the proximal part of the tibia is too osteoporotic as well as too small. And I also want that I will make the patient efforts so that he can bend his knee. I extended the fixator over the distal femur. These are the post-operative X-rays, one proximal tibia, distal segment, the cement spacer in between, and the distal femur ring. Distal femur ring has been placed with the hinges on the center of rotation so that patient will be able to bend his knee. So after 14-15 days, I am able to get clean stitch removal, make the patient bear weight, and make the patient bend his knee. This is his video. So after almost 2 months, when all the diffuse osteoporosis changes has been disappeared, the patient is bending his knee, the patient is walking well, I decided to go for the second stage and did the spacer removal and did the distal tibial corticotomy. So these are the post-operative X-rays. I have removed the distal femur ring, proximal tibia, a middle segment, and the distal tibia. So started the transport, second ring from the distal to the proximal. These are his sequential X-rays. The distal tibial reason rate is good. I have dissected for 3 times a day rather than 4 times a day. So as the dissection progresses, the main complication of the bone transport, the graft invagination came. And these are the clinical pictures as well as the X-rays when the middle part of the tibia got totally docked with the proximal part. I have kept this a conical part of the middle segment so that I can remove it at the time of graft invagination and docking. So in the third part, I have removed that conical part, make it transverse, docked it with the proximal segment, and close the wound. These are his post-operative after stitch removal. So I continue to learn from the distal side just to make the limb lengths equal. And this is his full length X-rays, almost 21.5 to 22 centimeter region rate. This is his X-rays just to show how comfortable he is taking bath, everything is walking. And on one day, he fall on this fixator and had a hairline fracture on the new bone, on the region rate part. I have done nothing. I have just added a dummy ring just to equally divided that thing. Make the patient continue to bear weight, even continue to ride the stairs. These were his X-rays. The region rate fracture is healing well. The consolidation is going on well. Serial X-rays. This is the clinical video of stress test. I have removed all the rods. Make the patient bear weight. There is no pain, nothing. And these are his post-removal X-rays. These are his clinical pics after the fixator removal. The knee range of motion, although it is equal to 90 to 100 degree, but it is fair enough to make him sit. And this is his clinical video after the fixator removal. So this is all about this case. Thank you very much. Any questions?
Excellent case, Rajiv.
Thank you, sir.
Done well.
Thank you, sir.
What was your post-operative physiotherapy protocol?
Sir, nothing, sir. No physiotherapy services have been taken. I have just made patient bend his knee over the hinges and taught him how to bear the weight. Nothing else, sir. That I have also taught him not to let the foot go into the plantar flex, keeping the foot braces and all that routine stuff in the individual also. Nothing anything special, sir.
What was the total duration of fixator?
Sir, 1 year, 7 months, sir. From the first day, 3 surgeries and total time of removal, 1 year, 7 months.
22 centimeter bone length.
22 centimeter bone length. The patient is weight bearing ambulated from the very day one, sir. Never
Well
on the
done.
bed. Thank you, sir.
Hello,
Hello. Yeah.
Dr. Rajiv.
Yeah. Hello, sir.
What will be your rate of dissection?
Sir, because it is the distal tibial corticotomy, I have dissected 3 times a day, 0.25 mm 3 times a day.
Okay, 0.75 per day.
0.75 per day.
And it goes till 1 mm or it is 0.7 per?
No, sir, for the whole of the period, he has dissected 0.25 mm per day. 0.25 mm 3 times a day. After every 8 hours.
Okay.
Any more questions?
Good. You had tough time.
Thank you, sir.
Sir, can we move on to the next talk?
Yeah,
you,
we
sir.
can proceed to next case.
Thank you, sir. Sir, next talk is by Dr. Deepak Sahotra. Sir, please share your screen.
Good evening, everyone. So, my talk is on non-union distal tibia, which had an implant failure and was managed by Lizaro. So, regarding the history, this patient she was a 60-year-old female and she sustained a distal tibia and fibula fracture at the same level, and it was around 4 to 5 centimeters above the ankle joint. So patient was initially managed by close nailing and there was no fixation of fibula done at that point. So after 4 to 5 months, patient was walking from day one and was complaining of pain and swelling at the fracture site. And at 6 months, he presented to the concerned surgeon who did the procedure with a broken distal end nail. And 6.5 months, he presented with a broken nail at distal site at my hospital. So how did I manage this? Since it was a difficult task to remove the nail closely, so I had to open the fracture site and remove the nail. So fracture sites were freshened up initially, and dead necrotic bone was removed. Then Elizaro was applied with 3 ring construct, and corticotomy was done between first and second ring. There was a gap of more than 1.5 centimeters between both the ends. So I started a dissection at 7th day at a pace of 1/4 mm, 4 times a day in 24 hours. So it took around 4 weeks to close the fracture. So it took around 6 months for the fracture to completely unite and to consolidate the regenerate. And frame was removed after 6 months. So these are my clinical pictures. This was the initial presentation, and patient presented to the concerned surgeon where nailing was done. So you can see the fracture at the distal end of the tibia, and the fibula is also fractured with the combination at the same level. So this was the nailing done at that time. So you can see the nail is properly fixed, and you can see the distracted fibula fracture is also there, but it was not fixed. So this happened after 5th month. So you can see 6th month. So you can see the distal end of the nail is broken, and fracture is not united, and it is totally distracted. And here you can see when she presented to me, I just removed the nail, and these were the initial pictures. Then at the time of the Elizaro fixation, so I just removed the dead necrotic bones, and there was a gap of around 1.5 centimeter between both the ends, and both the ends were freshened up, and fixed the tibia with the three ring construct, and the corticotomy between first and the second ring. So these are the clinical pictures with Elizaro frame on after a week or so. She was completely weight bearing with the help of a aid, and these are the continuation pictures after the dissection. You can see the beautiful callus form at the fracture sites, And these are the clinical picture at the end of the 6 months. So this is the clinical picture. She is walking with a proper gait, with a mild bug gait, and these are his clinical pictures while climbing the stairs. Thank you very much.
Sahotra,
Yes, sir.
what is your own opinion about your case, end result?
Since patient had a
End result.
end results, the thing is this
Are you
Elizaro.
happy with yourself?
I'm happy, but not with the alignment.
Yes. So there's a way of improvement over there.
Maybe I must have used a Shan spin for proper.
No, the digital ring is having only 2 wires.
Yeah. No,
That
no.
is not stable enough.
Yes, sir.
That is not stable enough.
Yes.
In it, originally you got good place, good alignment.
I should have aligned, augmented with the Shan spin on both
Whatever
the sides.
you want, it has to be stable.
Yeah. It was unstable.
Yeah.
So that is one of the reason it
Why
has
did
not
the
aligned
tibia nail fail?
Tibia nail failed because of
Just show that X-ray of the
I will
nail.
show that actually.
Why do you think it failed? Because then that will give you the answer to what.
The one reason of failing tibia nail was that fibula was not fixed.
No. Fibula doesn't need to be fixed. You
and,
also didn't fix the fibula. So you think that the Elizarov is such a fantastic tool that in spite of not fixing the fibula, you got it to heal?
I think the fibular distal end of the nail is not at the proper side.
That is one. And second is, it has, see how the nail has failed. The fracture has continued to go into flexion.
Yeah.
Or procurvatum. Right? So that is the alignment part. So if one could get this well aligned, it's difficult. In distal fractures, that's why you have all these multi angle locking nails, etc. So, but if you can get it into the proper alignment, there is every likelihood that this would heal even with a nail.
Nail.
Right. Here the problem was not necessarily the biology, it was the
alignment of the nail.
Alignment.
Yeah.
Now go ahead to your X-ray with the fixator. Okay, there is a little bit of procurvatum even over here.
Yes, sir.
So if you have to, even with your ring fixed like this, so this is a statement that Dr. Vasudevan makes often, that if you don't have enough hold on the bone, you may try and angulate the rings to each other, that is distract posteriorly and compress anteriorly, thinking that this will align the fracture. But if your hold is not good on that, then the rings will move, but the bone will not move.
Yeah.
Right? And there was a clinical picture. Just show us the clinical picture of the lady. Yeah. So this is pretty large size rings. You probably would have got away with one size smaller.
This was 200 mm. So
Correct.
probably 180 was the best size, I think. So.
Yeah, 180 or 160. So that normally is what again, that reduces your stability. So though she is walking reasonably okay, but you try and get, so this is what Taran was talking about, clinical and radiological.
Yes, sir.
I don't know what was the word he used. I use audit but he used some other word. What he said? Learning curve.
Learning curve.
So when you
prospective and retrospective analysis, learning curve.
वो बड़े शब्द यूज करता है वो. मैं सिंपल ऑडिट बोलता हूँ, वो प्रोस्पेक्टिव एंड रेट्रोस्पेक्टिव डिटेल्ड स्टडी ऑफ माय पेशेंट ऐसा. हाँ ठीक है. But the point is that whenever we are doing something, so Vasu asked you, are you happy with it? Right?
No,
and
I'm
you
not
said
happy.
you are happy. No, it's correct. You should be happy. The fact that you are able to get healing.
I'm happy because bone is united, but not
absolutely, absolutely. But then the next question has to be, okay, is there anything less remaining? So now with the procurvatum and what we saw in Taran's case, there is a possibility of ankle osteoarthritis in the future. So, and all of us have done this. Difficult case mein we got healing, and then we are looking at, okay, you know, is the patient's walk perfect? Is the angles perfect, etc., etc. So that is our normal process, so to speak. Is Altaf still there, or Altaf is left? Altaf?
I think it's left.
Okay.
He's
So there is-
he's still on audio, I think, sir. Not active.
Okay.
But anyway, you are very good healing, and this is the stage where we can think about improving ourselves.
That's true.
So what went wrong? How can I improve myself? Where should I put my pins or?
I'm here only, sir.
So then why are you not answering? Why are you hiding?
because इसमें दब नहीं रहा था इसमें.
अच्छा.
इसमें दब नहीं रहता. I agree totally with you, sir.
So
again, the same thing is that the distal fragment being small, that's why it has tended to be more unstable. And as you rightly pointed out, then went into procurvatum and broke. So alignment again is the, I think, primary thing to settle these issues.
Couple of questions in the chat.
If there is a
आवाज आपका टूट रहा है. I think who is that?
Not audible. Rajesh sir, आपका आवाज नहीं आ
आपका
रहा है.
आवाज टूट रहा है.
Rajesh sir's audio is
in this case the distal fragment. Okay, so we can go across ankle or across knee for 6 weeks. That can be suggestion.
So can you explain that again?
Your voice is
not
not
audible.
heard clearly, Rajesh.
I can go across
Say
ankle
again.
or across knee in case of less stable fixation. That was
Extend
I said.
across the
For
joint
6
is what
weeks.
he's saying, if you have a small
Yes,
fragment.
Okay.
But this was a pretty large fragment. I would not, even much smaller fragments than this, we would put it. But when you are starting out, if you're worried, yes, you can extend. But you can, if you use all the tricks that we talk about, drop wires, crossing angles, etc., then much smaller fragments than this also you can get stabilized without going across the joint. There is 2 questions on the chat. Jitendra Wadhwani is asking, for an oligotrophic regenerate, what works better, autologous bone marrow injection or anything else? I am not a big fan of autologous injection. I'm not sure that it's the injection that is working. If I'm worried about healing, I would take cancellous bone graft as the gold standard. Otherwise, if you are giving 3 injections at 2-week intervals, for example, then it may be just the 6 weeks gap that is showing you the better result. Anyone has a good experience with autologous bone graft? Because if you spin the graft and then get mainly the cells and all that may make some sense in terms of you're getting osteoprogenitor cells and all that. But taking out 20 cc of bone marrow aspirate and then injecting that, I wonder how helpful that is. If someone has experience, I'm happy to listen to them. You have some experience, Jitendra?
Sir, I have experience of only autologous cancellous grafting.
Yes.
Just in the chat, Dr. Vikas actually mentioned about the bone marrow injection at the regenerate site. That's why I was curious that something
Yeah.
minimal invasive can be done or not.
Yeah, just two cases actually. So cannot certainly say which is working. But first choice would be definitely the cancellous graft.
One more thing I read about this, sir, passing multiple like wires across the oligotropic area that stimulates the regeneration. Does anyone has any experience about that? I tried it in one case. It worked. I don't know. It worked because of that wires or something else.
I would say something else. You would have got a stable frame, you would have corrected the alignment, all of that, right? So I can say that okay, if I put on a frame which is stable and all of that, and then the final thing I do is put my hand above my head and turn counterclockwise 3 times. That is what helped my fracture to heal. So that is BS, na? So the important thing is the stability and your alignment. I think those two are the most important. I think last question is Dr. Swatantra. Incidence of OA ankle in failed managed with Ilizarov are variable to about 30%. I've looked upon. Can that justify adding a calcaneal ring for better stability? How will that, very Swatantra, how will that improve the incidence of OA ankle? The cause of OA ankle very likely in distal tibial fractures is when you have a force which is shattering the tibia. It's also likely that that is damaging the cartilage in the ankle. Plus minor things like what Altaf has pointed out. If our alignment is not right, etc., then you get osteoarthritic changes. So I'm not sure that a calcaneal ring for better stability, meaning if your alignment is good, even without the calcaneal ring, then why should you have osteoarthritis?
Good evening, sir. Sir, my question was actually the other way around. I wanted to know that if eventually we are facing OA in such relatively higher incidences, why not go for a calcaneal ring and not compromise stability and trying to avoid ankle stiffness? Like in this case, we had a procurvatum, which we feel was because of the stability.
Correct. So that's what I'm saying. If like me and Altaf and Vasu and the other senior guys here, you can get good stability on a small distal fragment with only the distal tibial ring, then that's the more convenient way of doing it. But if you are starting out and you're not sure and you want to add, nobody will ever blame you for adding more stability with a calcaneal ring, for example. So the answer to your question is yes, but at the same time, it is not always necessary. If you see our talks and all that, we have much smaller fragments with multiple crossing angles and crossing in the sagittal plane also, where we don't need to use a calcaneal ring.
Try to avoid calcaneum and put maximum pin in the distal fragment and get more stability. That's what Mangal says.
Yes, sir. Our usual practice is actually we try for this thing, tapered pin, but sometimes we are not very
a good
confident.
option in the
Not necessarily tapered pin.
Okay, okay, sir.
Maybe I will do 4 to 5 wires there, including olives.
Okay, okay, sir.
Well, let me just quickly share one. Just since we are on the point. So here's a non-union of the distal tibia. You can see?
Yes. Yes, sir.
So that's a very small fragment there. I have not extended anything across the knee. So I've got 2 wires there, another cross in the sagittal plane, going from below to up, and plus there is a shan screw. But suppose this fragment was smaller and I couldn't put a shan screw. I could put one more wire in this direction. So then I will have multiple wires in that. So she's gone on to heal without any trouble. But the important thing here is, as I said, alignment as well as your, let's see, where is the lateral? Yeah. So alignment as well as good stability as well as contact. So you don't always need, but if you have a small fragment like this and you are relatively speaking starting out and you
Yes.
see that, no, I'm not sure and I want to put in a calculator, no one can argue with you for trying to give a little more stability that is required.
Okay, sir.
And as
So if we,
you get more comfortable with it, you will start realizing, okay, how can I add more stability without extending? Because whenever you have a calcaneal ring, it is not as easy for the patient to walk as if the ankle is free.
absolutely, sir, absolutely.
Thank you, sir.
Sir,
Thank you.
may I add up one thing? Whenever we deal with tibia or femur, whenever the patient comes for the follow-up, if we have an X-ray from, suppose for tibia from knee to ankle, and draw all the lines in every follow-up, then we will come to know where the things are going, whether the distal tibia is going into varus, valgus, procurvatum. At that level, we can correct. So all the post-operative X-rays must have.
Usually it is a little difficult to get your X-rays from end to end. So what I like to do is I like to get, now that this lady that I showed, she has lengthening as well as, so I will see the joint above and most of the shaft below. So this is an X-ray focused on the regenerate side to look, so AP and lateral focused on the regenerate to look for is the angles okay. And then another X-ray which is focused on the lower portion where I can see that joint and most of it. The other way people try is to get, so you see, notice that this ring is kind of a single ring. So now I can see all of that when I'm doing the AP X-ray or the upper portion X-ray, the upper ring. So if you try to get everything into one X-ray, then sometimes it doesn't. As you go lower, you see the ring is looking more and more oval. So when you're doing a bifocal or a trifocal, good idea is to get to center on both of them. Oh, sorry, we're now finished in terms of time. We have overshot. Did you start a little later? Mute, Altaf. Yeah.
Just a second.
All right. I think we are done, no? In terms of talks, or is there someone still remaining?
So there are a couple of talks, sir.
Why are we so delayed? You started what time?
We started 5 to 7 minutes past 8, sir.
Okay.
We had a little
Sorry, then
technical problem.
I thought we had finished. That's why I was going on. You
No
should have
worries.
stopped me. Go on. Let
Okay,
the
sir.
next person speak.
Yes, sir. Dr. Jitendra Wadhwani, please share your screen.
Is it visible?
Yes.
Good evening, everyone. Myself, Dr. Jitendra Wadhwani. Thank you so much for the opportunity. And I will be presenting here a case of an 18-year-old male with history of road traffic accident, history of plating for fractured distal tibia on the right side, and plating for proximal tibia on the left. Left side got infected and the index surgeon removed and applied external fixator on the left side. And this is the X-rays. This is how patient presented to us, and we removed the external fixator. And you can see the interplex screw. Index surgeon left the interplex screw inside, and there was still non-unions, some gap here, and multiple reloads. So what we have here clinically is exposed necrotic bone, exposed implant, non-union, and a flexion deformity at the knee. What we planned is debridement of the necrotic bone, distraction osteogenesis with ring fixator, and a bifocal corticotomy. There was a huge amount of necrotic bone inside, and we debrided because of the plate which was initially placed, And after debridement, this was a picture clinically, and we debrided till the paprika sign, and there was 13 centimeter bone gap intraoperatively. And what we did, we closed the soft tissue sleeve, applied it Elizabeth ring fixator. The deformity got itself corrected under anesthesia after application of this fixator, and did a distal tibial corticotomy. It was a pre-op AP X-ray, post-op AP X-ray with the distal corticotomy, and there is a lateral X-ray showing a huge gap. And distraction started at 7 days after 10 days of latency, because I always choose to distract at a later date in distal tibial corticotomies and at a standard rhythm. But what you can appreciate here is there is some malalignment still there in the AP and some in lateral. I kept the distraction going on because there was soft tissue loss as well. And as the distraction proceeded, the malalignment became more and more evident clinically and radiologically as well, as you can appreciate this translation. At 4 months follow-up, the docking site was about to reach at this location, but patient was lost to follow-up, and actually he overshooted the docking site. So it was slightly over-distracted. It was a 5 months post-op. And as you can see that slight overshooting at the docking site and necrose bone exposed there. And there's a proximal fragment going into valgus, and there's slight overlap. What we planned is the open docking and realignment of the flame. And this was docking site was disconnected, and actually docking site open docking, some views was shared by Dr. Mehul Khatri and Amar Soni sir as well in the ASAMI group. And briefly describe the surgical technique here. There is the expected alignment after correction of valgus. And this is the technique how it is done: transverse incision proximally and distally, and you remove this patch of the skin, and excision of the invaginated soft tissue. And this is the clinical image. And this is the final picture after debridement. We actually distracted downwards and pulled with traction. And with the help of threaded rod, we did the docking. And this is after the closure and final clinical picture. But within 3 days, it started to get necrose because might be some too many of sutures we used. And we managed it with the local wound care, and we got away with that. At 6 months follow-up, we had a good alignment at the docking site, but there is still some virus at the fracture site. 8 months follow-up, we waited for regenerate to consolidate, and we achieved union at 12 months. But still there was some virus and a slight recurvatum, but patient was having an acceptance towards that. And at 20 months follow-up, patient came again, but with a broken plate on the right side. Bad luck for him. But luckily, we got very good X-rays, and left side there is slight virus, but union completely achieved, recanalization of the regenerate. But not to forget to mention, the ankle is still in slightly equinus. This is the final clinical pics after 20 months of follow-up. Slight recurvatum here at the initial fracture site, and you can see the stretch mark how the regenerate was formed. And there's a good range of motion, and this is, I think, the video of the clinical range of motion. This is the knee range of motion, full almost full flexion, complete knee extension, but ankle is not having much of the movement. As you can appreciate, the limb lengths are almost equal. But there is a slight recurvatum. Patient is not worried about that, but he's definitely worried about this ankle equinus, which is still persistent. And we got from this to this overdocking, and finally this. What I could have done better, I think a tricortical convergent corticotomy would have decreased the fixator index time, but I'm not very much disheartened by the index here, 1 month per centimeter here. And I should have applied foot frame initially to prevent the equinus in the index surgery. Thank you so much. Comments are welcome.
So how would the foot frame have prevented equinus?
So during distraction, I think because of the distraction, there is a differential growth. Muscles remain at that place, and all the stuff. But equinus, I would
No,
have
I
applied
don't know all the stuff. That's why I'm asking you.
there is a differential growth between bone and the muscle, and when we go from top to bottom, there is contracture of the gastrocnemius. So I would have prevented it and slowly
No, you went
applied.
from below. You went from below upwards. If you go from top to bottom, you will not get this much equinus. Even if you hold the ankle, it is very likely that you will get your toes clawed.
Okay.
When you do a distal to proximal transport of this length. And the reason is that all of your flexors of the ankle and toes are, rather not ankle, of the toes are taking origin from that fragment which you are pulling up. So as you pull them up, the muscle kind of refuses to lengthen or lengthens less, and then you get this kind of an issue. So not only a foot ring or a heel ring, but also I think putting in K wires into the toes to keep them extended is a good idea.
Yes, sir. Thank you so much for your input, sir. Any other comments, sir? What I could have done, let's say.
When you're excising the bone,
yes,
it's always better to excise a little more bone for your open docking. That is, the skin ends should overlap the bone, or the bone ends should be within the skin edges. That way, when you do your acute docking, you have kind of redundant soft tissue and you don't have to apply tension. Now, what Amar has pointed out is, even if suppose you don't get closure, you just approximate it without tension and keep compressing. So that soft tissue will come together. On the other hand, if you try to close it under tension, then you will lose against some skin.
Indeed, sir. Definitely. Thank you, sir.
One thing I can say that how much bone to be excised initially. This is the Jayant Sharma came in ASAMI and he gave a talk on how much debridement is enough debridement. Now that things are going that you should not do radical debridement, you should do the they can say required or adequate debridement. But if the bone is in continuity, then you can do less debridement. You can paprika sign may not be only followed to do the what is the avascular area. Even some avascular bone is there, but it is in continuity of the vascular bone, it will vascularize. So I think when I went to this deformity course in Hull, there also there were many speakers saying that you should do less debridement.
I may not agree totally with that. One of the reasons being that if we start giving this message of doing less debridement, yes, adequate debridement is all right, but उसमें क्या होता है कि people start doing lesser debridement than is what is required, and then that damn thing doesn't heal because there is backbone left. Here, from what I could see, what he has taken out is the absolutely dead bone, which was like a sequestrum. I don't think he has taken out much more than that. And at the most, what happens is you are adding, let us say you are adding 2 months of fixator time. To a certain extent, I think what the kind of infections we see is not seen in the West.
In West, I totally agree with you. Totally agree with you.
वहाँ पे जो है it is lesser. So therefore, that is one thing that also we should keep in mind. Yes, we always talk about, you should not do excessive because that adds to your time. But if you are in
Yes.
doubt, I would say that, the
You
debridement
should
is
remove.
more
I
important.
agree with you. I just heard that, and so I said.
Yeah, fair enough. I mean, that is
And
a
one more thing, sir. If we just keep that some amount of bone which is in continuity should be left, then I think we'll be losing objectivity here because red paprika sign is like standard for us, all of us. And if we keep like someone is keeping 2 centimeter more, someone is keeping 3 centimeter, 5 centimeter more, then what is the upper limit if we keep the extra bone?
No,
Or
that's exactly the point I'm making. That Hemant Sharma, with his experience, may be able to decide that okay, this will revascularize. Vasudevan, Altaf may be able to decide. But when you are dealing with difficult situations, especially when you are lower in the lower, in terms of experience, then you may run into trouble. So this both these things have to be balanced.
Still,
What
the case
Rajesh
is
is
very.
saying, it has to be balanced.
It's more
Yes,
of a
sir.
feeling. You'll get that feeling there when you do it.
Yeah, but his point, Jitendra's point is that,
Yeah,
he's too young to have developed a feeling for
that's right.
dead
But
bone.
the usual rule
You
is
and I have.
when you think it is adequate, do a little more.
yes.
So
All
can
right.
we use the
How are
Yeah,
we
PET
for
Dr.
time?
Ved
The same
wants
way,
to say
the
something.
same way when you fix the fragment also, when you think it is adequate, do a little more. So here again, your proximal fragment was not stabilized well. When you try to
Yes,
compress
sir.
the docking side, the proximal fragment may misbehave. So
Yes,
there
sir.
you have got only 2 or 3 pins.
Yes, sir. 3 wires were actually there. No transpin was there. Now I
Yeah,
expect that previously I should have added a half pin there. So
yeah,
it would
that's it.
have gave me 2 cortexes and
So
from the offset of the ring. Because
regarding stability also, when you think it is adequate, put one more pin, one more wire. Like debridement.
once
When
it
you
is,
think it is
yes,
adequate, little more. When you think the stability is okay, put one more.
yes,
Because
sir. I
one
agree.
more wire is not going to take much time.
Yes, sir. Yes, sir. Thank you, sir.
So
Okay.
for measuring
Thank you.
the amount of debridement, can we use a PET CT or to actually measure
How
what
will
kind?
it do? No. PET CT will show you where there is infection. It doesn't show you which bone is dead. And you can't replicate that on table. If the debridement is done on table, PET CT is okay to see skip lesions or the extent of debridement intramedullary, etc., but not for deciding what bone is dead or not dead. We have shot over. Now we'll go to the next case.
Yes, sir.
Thank you, sir.
So next talk is by Dr. Gaurav Sanjay. Please share your screen, sir.
Good evening, everyone. Am I audible and is the screen
Yes.
visible?
Yes, sir. Please go on full screen.
Yeah. Is it okay?
Yep.
Okay. Thank you, everyone. So I'll be speaking on a case in which there was a proximal tibia non-union. So this is a 39-year-old gentleman. So he had an injury in 2021, and this was due to assault. And you can see that this is sort of an undisplaced fracture of the proximal tibia extending into the diaphysis also. This gentleman, he works as a part-time goods sellers in Himachal. Financially, he was not very well off. And he also had some issues of neglecting his treatment also. So initially after this assault, he did not have any x-ray for the first 15 days. The first time he went to a chemist who apparently thought that, there is not much injury, and he just gave him some painkillers. He was negligent to show to an orthopedic surgeon. Finally, maybe he had a little more pain, and then he went to a medical college. So this looks like a very innocuous proximal tibia fracture to me, at least. So this is a quite something to learn from this also. He was initially put on a plaster cast, and this is a 3 months follow up from this was done elsewhere, and you can see that still looks quite innocuous. Maybe somebody wants to change his conservative treatment into a definitive internal fixation. This is at 4 months. He was still maintained on plaster. He went to another medical college. They still advise him that, they hope that, this will still unite. Please continue the plaster. This is at 7 months, roughly. He was on plaster for, 5 to 6 months. An above knee plaster was put. He had a quarrel with the current doctor that because of his persistent plaster for 5 to 6 months, and he had a lot of discomfort in it. So he forced him to get the plaster removed. And then he went to another place where above knee bracing was done. And even despite his brace, he was still not very compliant. He says that, when I used to walk, I was wearing the brace, but not at rest or, while he's at home. This is at 10 months. He was still on bracing, not very compliant with it. But you can see that there was some visible callus on the medial aspect and the posterior aspect of the tibia at the fracture site. He went to another surgeon, advised to continue bracing. He was hopeful because probably he saw some callus. He said, continue bracing for 3 to 6 months. And with calcium supplements, I'm hopeful that, this will unite. This is at 21 months. So you can see that on the medial side, that callus has improved, but there's frank non-union. This is how he presented to me at around 22 months, around 2 years. And he has almost 40 degrees of varus. This is his pre-op video. I mean, at the time of presentation, this is how he walks. So we decided to go ahead with an Elizarov with gradual correction of the varus, put in a 4-ring stable assembly for this gentleman, and then gradually distracted the rods on the medial side to correct the varus. We were able to achieve his varus correction within around 15 to 20 days. At even 5 months post-op, what we found was that there was not enough callus formation. If you see the lateral view, AP view, the correction was adequate and it was corrected. But due to his oblique nature of the fracture, so what we planned was that we would do an intermedullary reaming and did a fibrectomy and readjustment of the fixator. The intermedullary reaming was decided so as to open the blocked intermedullary canal. Patient was informed at 7 months that his signs of healing were still dicey, and we advised him that you can go for a plate fixation or an intermediate rod fixation. I would have preferred to do a plate fixation for this gentleman, but he was still reluctant and he refused that. I just want to continue with the fixator, and even if it takes time, I'm willing to wait. This was his X-ray at the time of removal of his external fixator. The fixator time was around 17 to 18 months. We lost him to follow up in the last 6 months of his treatment, although he would, consult on the phone occasionally that he's having some pin tract infection. He never showed up to the clinic to get any treatment after any physical examination. Although at the time of his fixator removal, I could see that the pins in the distal fragment, they were completely loose, and occasionally when he was calling before, he would just ask some antibiotic on the phones. So as I said that 17 months was his fixator time. He was ambulant on the fixator since day one. This is his video prior to removal. I'm sorry that he's has a pajama over it, but he was very comfortable with it. This is at 2 years. When the fixator was removed, and he came for a follow-up even after the fixator was removed. His union was achieved. His lack of funds did not allow him to pursue internal fixation after correction of the deformity. He's very happy with the outcome. Although I feel that there's slight valgus which was developed at the non-union site, but ultimately this is how he could walk. This is his final photograph. He accidentally came 2 days before, and he came with another patient. He says that he has an on and off non-healing wound on the medial aspect of the ankle. I feel that there might said that his frame was became due to the site infection. Else he's very happy. So learning points is that even in a complex deformity and non-unions, they can be addressed with the Elizarov fixator. This was managed closed entirely. A close follow-up is necessary. Sometimes patients are not willing to come very frequently. Elizarov always remains a viable option for such patients. Thank you very much for a patient hearing.
Dr. Gaurav.
Yes, sir.
Yes, sir. I have one concern. You see, to begin with, what was the problem with this patient? Was the intact fibula.
Yeah.
And that's actually what had led it. Otherwise, a simple fracture, why shouldn't it unite? And then
So
now
initially, sir, he also had a fracture of the fibula.
But that had united. And what happened
Yeah, it
in your
united.
case also,
Yes.
and if you go through your case also,
Yes.
your
Yes.
ring also, the osteotomy in fibula must have healed very fast. And
Yes.
that is why it took a while in uniting. And
Yes, I
second
agree.
thing is, the fracture anatomy to begin with was a shear.
Yeah.
It was a shear force to
Oblique
begin.
fracture, definitely so.
So even if you had an axial loading, the shear would continue.
Yes.
That's why you have had so much of a time delay for this to unite. Otherwise,
I
a
agree.
closed fracture. So in other words, in case you want to do a fibulectomy, in case you want to have a compression, you can have a oblique cut so that the fibula overrides.
I agree.
Or you could take a segment. Otherwise, naturally, if you are just doing a fibulectomy, fibular osteotomy, it's bound to unite within few days, few weeks, and then your problem continues. That's
I
why
agree.
what has happened. And then
I agree, sir.
second thing is that maybe that there could be a criticism that this could be managed very well with the simpler methodologies, like a nail or something like that. With a did fibulectomy, it should have had. Perhaps even if once he was in a plaster and somebody had done fibulectomy at the earlier stage, he would have perhaps united within the plaster even. That's my take on this.
Gaurav,
Yes, sir.
how do you correct the proximal deformity with 5 polyaxial hinges?
Sorry?
How do you correct the proximal tibial deformity with
Yeah.
5 polyaxial hinges?
Sir, the hinges were put definitely just to his main problem was the varus. So what I did was just gradually increase the size on the middle side and
Based
distracted
on
it.
what? What is the
Sorry.
how do you increase the rate? What is the parameter of increasing it? Like 1 millimeter distraction, you must get on
No,
the
for this,
contract.
sir, because it was a frank non-union, so I just
Okay.
wanted to correct the alignment.
Then
So
why
this
couldn't
was
you correct it all of a sudden on table?
I could have, sir. So what I felt was that because the soft tissues might have also create a problem in this case. So I just wanted to be a little gentle on the patient, because sometimes if you do acute correction, these patients have a lot of post-operative pain also. So because time was with us, I don't think so.
But
But
at
Dr.
what rate
Vasu
you
is
do
telling
correct?
you,
acute
Dr.
correction.
Vasu is telling you, why not on a hinged based? Why these 5 polyaxial hinges? How would you manage a deformity correction with 5 polyaxial hinges? Like if you simply he had a varus deformity, you had a motor unit on the middle side and couple of hinges at the cora point, that would have been enough. And you wouldn't have to do kind of acute correction and then pay and all those things in the world. So how do you go? The idea is how do you go about this? Like Dr. Basu rightly point, how do you go about deformity correction with 5 polyaxial hinges? What is the idea behind it?
The idea was just that, if in case there is any other part of the correction I wanted to do, I could have addressed it with these polyaxial
Yeah,
hinges.
Gaurav, just
No, but
teach
that,
me how I should go about it. How much millimeter distraction on that rod and the other rod and
You
also
heard,
how should
you
I
Sir,
heard
do
in
it?
on
the first
this,
talk,
in,
you heard in the
sir, in
first talk, 1 millimeter distraction, 1 millimeter
yes,
per day is what leads to bone formation.
yes.
So with this complex situation, how are you able to ensure 1 millimeter distraction at your regenerate or non-union site?
Sir, actually, in this, what my plan was that I wanted to correct the alignment slowly. It was if I provided enough stability. This was not in relation to the regenerate because he came to me at 2 years. So this was everything was done in a closed way. My
So
point was that when I
were
was
you
increasing.
using the Elizarov fixator or were you using the Elizarov principle?
No, I used the Elizarov fixator to correct the deformity.
Prior
And
to
then once
prior
the
to
alignment was corrected, then I just wanted to make it stable. That's it.
Where was your Cora?
Cora was at the non-union side, sir.
Both
Dr.
AP
Gaurav,
lateral,
what these
front of
senior
frame,
guys are
assisted
trying to
frame.
tell you is that you have to use Elizaro not as a fixator only, but use the principles. So simply a simple varus deformity with a motor unit on the medial side and hinges at the cora would have done your job. You
I
didn't
agree, sir.
need to make it so complex that you would be distracting in point one, another point two, another, and kind of a complex thing to create. It would have rather, there was only always a possibility of creating a rotational deformity. Because if you erred towards doing some inappropriate distractions in so many multiple hinges, it would have led to a rotational deformity rather
I agree,
than.
sir. Could have happened. I agree, sir.
No, Gaurav, now I've seen 2 cases where polyaxial hinge is used for the non-union side, and both of them took very long time.
I agree,
Agreed.
sir. Oh, I agree. I agree to your point.
So why it has happened?
It's probably because there was instability as a result of the polyaxial hinges, as Mangal sir had pointed out earlier.
Yes.
I agree.
But Dr. Vasu, in his case, I again would say that his fibula again united very fast. And that's
Because he has not fixed the fibula.
yeah, that again led to again it united first
Yeah,
and then tibia
when
remained
he
same.
has fixed only the tibia, no?
Yeah.
So the fibula is free. It's a free bird.
So if we are done, can with the permission of chair, can I show one slide? One slide because I wanted to make that point clear to Taran. Dr. Mangal, are you around?
Yes,
Please
please.
go
Go
ahead.
ahead.
I'll see if I'm able to I'm just looking in my laptop. I'm trying to kindly you. Yes, here we are. Is it there on screen?
Yes, sir, it is. Just about
Yeah,
to
yeah.
come up.
Yeah. So look at this. Look at this. Is it on?
Yes, sir. Go on, sir.
Is which? Yeah. So this was a proximal tibial non-union. So what I did a peg in hole docking here and did a distal transport. He was with around 6 centimeters of shortening. This is the transport area from below up, formed a good regenerate, and this was primary docking done at the site, and he united. But this is the point I wanted to tell Taran. I also have had this issue. Look at the distal fragment, because initially I had not incorporated foot in this. With the result, it went into procurvatum. And the point I am trying to tell you is look at this procurvatum and look at what has happened to the calcaneus. This is the compensation. So it has gone into towards a calcaneus orientation rather than being horizontal. And that's why I had to, because he started developing pain anteriorly. There was this anterior impingement. So I went again, from I think a year or two. Once he came again, and then I did this osteotomy, corrected the procurvatum. This is just immediately at the time of this surgery, intra-op. Then I corrected it even further. And now look at the talus. This is opened up. I think, have I been able to tell my point?
Yes, sir. Yes, sir.
Yes, this is what I wanted to. Dr. Vasu, are you around, Dr. Mangal?
Yes, yes.
Yeah, we are around.
Okay. So this is the point I wanted to make. I think this is clear somehow. The procurvatum developing at the distal end, then a secondary compensation at the ankle and the heel. It goes into calcaneus. While as once we correct the procurvatum again, and then the calcaneus goes back into its original position, and this anterior impingement is gone. Thank you very much.
So Dr. Vel Murugesan has raised his hand. He wanted to say something for some time.
Let him
Hello,
say.
sir. Hello.
Yeah.
Yeah, sir. This regarding this fibula osteotomy, with this shear fracture, with this shear stress across the fracture, does doing a fibula osteotomy increase the stress at the fracture site? Is the intact fibula a good thing to have, or we should do a fibula osteotomy when there is a shear fracture? If it is a transverse fracture, I do agree that doing a fibula osteotomy brings us more contact than compressive stress across the fracture site. Just your input on that.
So one thing is that the shear fracture in itself, it could have been a stiff non-union. So after you do the fibular osteotomy, you will know whether this is a stiff non-union or a lax non-union. If it's a stiff non-union, as has been shown multiple times, just distracting the stiff non-union with the principles of Ilizarov will lead to healing.
Okay, sir.
That tissue sort of whatever metamorphoses into bony tissue. That's number one. Number two, I don't think that an intact fibula, as is seen in this case, is a protector for forces. A shear fracture will always have shear forces. Then you have to have ways of protecting it from the shear, like for example using cross olives, or this is a good case for what we call a parafocal osteotomy, which I think one of them, some Girish or Dhruv showed it in the midterm meeting. If, for example, you do a transverse osteotomy after you have corrected it, then the shear is kind of avoided. So this is something you can read up, parafocal, and I think Dhruv has also shown it. So then the shear out of the equation.
The shear is shared by the corticotomy.
All the forces now come onto the corticotomy, and the shear, the original fracture site is protected, right? So that's another thing that you can think of.
And one more point is fibula is never, protecting tibia from the shear, as Mangal mentioned. You have to stabilize the tibia separately to control the shear. Fibula makes it free.
That's why we always put
olive and
olives, and we put tibiofibular wires always.
Yes.
Yeah. But in this fracture, the plane of the fracture is in such a way that you have to put an olive wire from anteroposterior to which is
you can put a shunt spin and push it posteriorly.
Or you can also use what is that? I forget the term for it. There is a thing where I don't know. It's called a traction absorption screw, or you can put in two screws across that fracture site, this is used in internal fixation regularly. Even if
interfragmentary screws. Interfragmentary screws.
Yeah, though it's not an interfragmentary screw in the classical sense where you have apposition, etc.
Yeah.
But when you put a compression screw across this fracture site, you are achieving compression the same way that you would with a olive.
Now, what I will do is I will do a cut olive from posterior fragment in the proximal fragment and push her from the front. You can put a olive shunt screw and push it backwards manually.
Okay.
Yeah, but this is also well described for internal fixation. Vale, you should know the
Yes,
the
sir.
terminology. What is that? Where you put in an intracortical screw, sometimes around nails and all that. Small screws.
Follow screws, yeah.
Mesonil.
Not polar screws. It is something like a traction absorption system, something like that. It basically
Okay, I don't know, sir.
neutralizes the shear. I'll find it. I'll put it on the ASAMI group.
Okay. Sir, and regarding that necrotic bone discussion, and sometimes I find that removing the bone and transporting it gets it unite faster than keeping the necrotic bone and trying to get those
Yes.
those two
Correct.
ends unite.
That's why I was pointing out that this, how much to take out to a certain extent depends on experience also, and if at all you want to, as Vasu pointed out, that if you're worried, it's better to take out a little more. It'll add a little time to the treatment, maybe theoretically. But in contrast is what you are saying, that you have good bone, which is liable to heal.
Even otherwise, when you do the transport, sometimes the tip of the transport fragment can get necrotic.
Okay, sir.
Right. So we are well over time.
Yes,
today.
sir. Just once I wanted to share my screen.
Thanks to Akansha, who gave them 10 minutes instead of 8 minutes. So we added 12 minutes straight over there, and then I added some, but we'll be better next time. Yeah, go on.
Sorry about that, sir. Sir, just wanted to update on the upcoming webinar, which is on Sunday. Shamshul sir is washed up, so he asked me to intimate everybody who's assembled here. And I wanted to bring to everyone's notice to send in their cases if they have any interesting ones. On 6th of September at 10 a.m., we'd be having it for 90 minutes. And I'd also like to bring to everyone's notice about our new website, asamiindia.com. So these were the two things I wanted to point out, sir. Thank you.
Okay, good. Thank you, everyone.
Thank you, sir.
Good night.
Thank you, sir. Good night, sir. Bye, sir.
Thank you. Thank you.
Thank you so much.
Bye, sir. Good night.
Bye-bye.
Bye, sir.